We are here to present an uncommon case in our daily practice, and for the implementation of this procedure we are 3 interventional cardiologists. My name is Itamar Ribeiro de Oliveira. To my left, Dr. Ludmila de Oliveira Ribeiro. We are both form natal, and on our left, Dr. Raul Arita from Argentina, working now in Recife and helping us in natal from time to time. The case we are about to present is a 1 year and 3 months girl who comes with a clinical heart failure caused by a fistula between the aorta and the right atrium. The treatment we propose for this case is that occlusion of the graft fistula within this fistula so as to close the communication, thereby permitting improved and the patient has a normal life. On this screen we are presenting the case. With the catheter we introduced through the ascending aorta, where we can observe the fistula between the ascending aorta very dilated. Forming an aneurysm, emptying into the right atrium. This fistula originates above the right coronary, seen in this image, as observed dynamically. Through the catheter, we injected the contrast, filling the fistula in the right atrium. The procedure adopted to put the prosthesis was, first we passed a coronary thin cord through this catheter into the fistula, then we went with a noose catheter.
Com um catéter laçamos essa corda e saímos com
Laced that rope and hung out with her for the femoral vein. This is catheter through the artery, and this guide we laced and pulled into the femoral vein, forming exactly the image resulting in a rail, as we can see. This catheter is placed into the aorta and the other one is exactly into the fistula through which he sailed over that rail. Why did we accomplish this? So we can come up with the prosthesis on the left side of the image and release it exactly in the distal portion of the fistula so that it is effectively occluded. In these images, we can observe several positioning tests. The contrast was injected through the catheter coming through the inferior vena cava, right atrium, and inside the fistula, and our goal is to release the prosthesis exactly on that point. We measured the diameter 4.3 millimeters and length 6 millimeters and chose a prosthetic plug Amplots 26. For measures questions, we conducted multiple injections of contrast that can be seen in different projections. For the prosthesis could sail, we changed the catheter and put an introducer 6F, and we can observe that it goes well straight into the introducer. We performed a test for this catheter coming through the aortic artery. Now our goal is to release it in exactly that position. In this image, we can observe the prosthesis being released, but still attached to the catheter. See that no longer exists passage of contrast injected into the fistula. This was repeated in another projection. In a first technique, we chose to leave this final tab in the right atrium, but noted that there was still passing contrast. Therefore, we repositioned it upward in position originally imagined and observed to be the most appropriate. In this image, we see the prosthesis being released and this other, the prosthesis fully released. We conducted a new injection of contrast to make sure that the aperture is completely occluded, including with a better opacification of the right coronary artery, which can be seen in this still image. We obviously consider the procedure a total success and cure of the patient.